Am I live? Please let me know in the comment section. Am I live? Just now, because of a technical glitch, I just ended the video, but now we have started again. So let me know if I'm live to you. Okay. Can you see what I'm drawing on the screen? So intracellular accumulations, pathological classification, and cellular aging. Yes, so you can see now. So let's continue. So today we are going to discuss the pathology questions. Okay. So first starting with the chapter. So see here, I think the screen is clear, everything to you. See, the first question is telltale sign of free radicals is the presence of dash. So here telltale sign. So here you can see the options are LDL, melanin, lipochrome and peroxide. So what are the uh, telltale sign of free radical injury, in which case you can see? So the answer is lipochrome. Okay, so see here, a telltale sign of free radical is the presence of lipochrome. So lipochrome is a telltale sign of free radical injury and lipid peroxidation. So lipochrome is a telltale sign of free radical injury and lipid peroxidation. Free radical injury and lipid peroxidation. Lipid peroxidation, lipochrome. Here, telltale sign of free radical injury. You can see it is also known as wear and tear. It is also known as wear and tear pigment of or lipofuscin. It is also known as wear and tear pigment lipofuscin, which is insoluble brownish yellow granular intracellular material which accumulates in various tissues like the heart, liver, and brain. So you might have heard about lipofuscin. So it is also known as wear or tear pigment or lipofuscin, which is insoluble. This pigment is insoluble. It is brownish yellow. It is granular. It is intracellular material present inside the cells, which accumulates in various tissues. Like you can see this in heart, liver, and brain. Image, if you see the image here, the longitudinal section through the cardiac muscle shows lipofuscin pigmentation. So this brownish yellow pigment is all lipofuscin pigments. Okay. So the longitudinal section through the cardiac muscle shows the lipofuscin pigment. Next question. There's a 45-year-old man who develops. I have to change here again. Some settings are required. I have to change this to rotate this to this way. Okay, so let me. Okay, so now I think it will be clear. So you can just rotate your phone so that you can look at it. Okay, fine. So now it is more clear, I think. So this the channel is in. Uh, so which one will be better? I'm not able to figure out this. This way the view is good or that way. If it is 19 is to 6, then it is better, I think. I have to do some settings. Anyways, I'm not able to set much, so I think this is also clear. You can see, or this way also it's fine, right? I think this is better. Okay, so see here, we can go either way. So if you see a 45-year-old man, he develops encephalopathy. On examination, his liver span, here the liver is affected, was found to be increased. His outstretched hands Outstretched hands exhibit asterixis. His blood ammonia was found to be increased. So liver problem. Representative microscopic appearance of his liver is like this. Which of the following etiologic factor most likely to lead to these findings? So let's see the options. Options are atherosclerosis, alcoholism, thrombosis, and hemolysis. The person is having this kind of picture, and his liver is damaged. So the most common is alcoholism for the liver damage. The image shows hepatic macrovascular steatosis, that is fatty change, along with intraparenchymal cholestasis. Arrows if you see. So look here, these are macro steatosis. These are big fat molecules deposited here. So these are macro. So this is these two alcoholism mostly. Okay. So the fatty change and intraparenchymal cholestasis. Intraparenchymal cholestasis. These are intraparenchymal cholestasis. Intraparenchymal cholestasis. These are intraparenchymal cholestasis. So these big macro, you can see now, these are the fatty change you are able to see. These are the macrovesicular steatosis, fatty change. So the lipid accumulates in the hepatocytes as vacuoles. These vacuoles have a clear appearance on H and E staining. So there is a clear appearance on H and E staining. Fatty change is mostly seen in the liver because it is major organ involved in fat metabolism. However, it may also occur in heart, muscles, and kidneys. The most common cause of significant fatty liver in developed nations is alcoholism. Non-alcoholic fatty liver disease is associated with diabetes and obesity. So non-alcoholic is associated with the diabetes and obesity. The most common form of lipid accumulation is triglyceride. The lipid, the macrovesicular steatosis, what you can see, that is nothing but triglyceride deposition. In alcoholic, it is due to alcohol consumption, and in non-alcoholics, it is due to diabetes and obesity. And here the lipid accumulates in the hepatocytes, the cells of the liver, and as vacuoles. Okay, and these appear as clear in H&E staining. The fatty change is mostly seen in liver. Other organs can also be involved, but liver is the most common. Next question, coming to next question. There's a 63-year-old man, and he complains of recurrent bone pain, and the diagnosis of multiple myeloma was made. Bone marrow aspirate shows the presence of Russell bodies. These bodies are accumulation of. So there's a 63-year-old man. He's complaining of bone pain, recurrent bone pain. Diagnosis of multiple myeloma is made already. So bone marrow aspiration shows the presence of Russell bodies. These bodies are accumulation of what? So the options, if you see, cholesterol, immunoglobulins, lipoproteins, or phospholipids. Russell bodies are due to immunoglobulins. Russell bodies are due to immunoglobulins. So if you see, Russell bodies are due to deposition of immunoglobulins. Russell bodies are globular intracellular accumulations. They are deposited inside the cell, immunoglobulins. And what cells are plasma cells? These are characterized by the accumulation of multiple Russell bodies. So Mott cells are the plasma cells, and these are characterized by accumulation of multiple Russell bodies. Russell bodies are globular intracellular accumulations of immunoglobulins, and if there are multiple Russell bodies in the plasma cells, that is called the Mott cells. These accumulations can be seen in plasma cytomas and plasma cell neoplasms. Plasma cell neoplasms and plasma cytomas. Okay. See here, these are the Russell bodies. In Russell bodies, you can see deposition of the immunoglobulins, globular immunoglobulins. If there are multiple other than in the plasma cells, then it is called Mott cells. This is because of these accumulations are seen in the plasma cytomas and plasma cell neoplasms. Okay, plasma cells, because these Russell bodies are deposited in plasma cells. Multiple myeloma. Okay, Mallory body or alcohol. Mallory body, you might have heard this term. Mallory body or alcoholic hyaline body is an eosinophilic cytoplasmic inclusion in liver cells characterized by alcoholic liver disease. What is the intermediate filament that is present predominantly in these inclusions? So the options, you can see, neurofilament, keratin filament, desmin filament, and vimentin filament, as you can see here. So these are the options. Let's see the answer. So here the malary body or alcoholic hyaline body is an eosinophilic cytoplasmic inclusion in liver cells which is characterized by alcoholic liver disease, which is the intermediate filament that is present predominantly in these inclusions. So if you see, the correct option is keratin filament. So malary bodies, they are also called alcoholic hyaline bodies, and these are predominantly composed of keratin intermediate filaments, that is keratin 8 and 18 filaments. Keratin intermediate filaments, they consist of the keratin filaments. These are clumped amorphous eosinophilic cytoplasmic inclusion bodies in ballooned liver cells that are seen in alcoholic liver disease. So these are clumped, these are the clumped one. These are irregular, amorphous shape and eosinophilic cytoplasmic pinkish, and inclusion bodies are ballooned. Are in ballooned liver cells. Inclusion bodies in ballooned, the liver cells are ballooned, and these are the clumped amorphous eosinophilic cytoplasmic inclusion bodies in ballooned liver cells that are seen in alcoholic liver disease, that are called malary bodies. And malary bodies, it is also called alcoholic hyaline bodies, and these are predominantly composed of keratin intermediate filaments. If you see the cytoskeletal proteins, these are divided into five classes. The keratin filaments characterized by characteristic of epithelial cells, neurofilaments for the neurons, Desmin filaments for muscle cells, vimentin filament for the connective tissues, and glial filaments astrocytes. So learn these guys. So there are five different types of these cytoskeletal proteins. How many? Five different types. So here you can see these keratin filaments. Keratin filaments are seen in the malary bodies or alcoholic hyaline bodies. These keratin filaments are deposited. Okay. These are composed of the keratin filaments. Malary bodies are predominantly composed of the keratin intermediate filaments. If it is a neuron, it will be a neurofilament. If it is a neuron, it will be a neurofilament. Okay. If it is a muscle cell, desmin filament. If it is a connective tissue, vimentin. If it is a astrocytes, then it is a glial filaments. The neurofibrillary tangle found in brain in Alzheimer's disease contains neurofilaments and the proteins. If you see in the Alzheimer's disease, the neurofibrillary tangle found in the brain in Alzheimer's disease, they contains neurofilaments and the proteins. Image given below shows the malary bodies marked in arrows. See here. Where is that image? The image is not given anyhow. Let's see the next question. The question says a 66-year-old man, he is diagnosed with squamous cell carcinoma of the right lung. While performing a pneumonectomy, the thoracic surgeon notes that the hilar lymph nodes are small, that is 0.5 to 1 centimeter in size, and jet black in color throughout. The microscopic appearance of one lymph node is seen here. Which of the following is the most likely diagnosis of the lymph node? 66-year-old man diagnosed with squamous cell carcinoma of right lung, performing a pneumonectomy. Thoracic surgeon notes that hilar lymph nodes are small. The hilar lymph nodes are small. Okay, the size is small. Okay, and they are jet black in color. The microscopic appearance of one lymph node is this. Which of the following is most likely diagnosis for this lymph node? Whether it is anthracotic pigment, or it is metastatic carcinoma, or hemosiderosis, or accumulation of melanin. So the correct answer is anthracotic pigmentation. See, the above microscopic image shows a black colored pigment. Okay, within the macrophage of hilar lymph nodes, it is characteristic of pulmonary anthracosis. It is characteristic of pulmonary anthracosis. That is nothing but the black color is due to deposition of carbon particles. If the carbon particles are deposited, guys, then the anthracotic pigmentation, because of this and because of the pulmonary anthracosis, because of the inhalation of the carbon particles, this pigment is deposited, and that's why it is very black in color, and these are present within the macrophages of the hilar lymph nodes. Okay. Okay, Talking about this, the inhaled carbon particles are engulfed by lung macrophages, and they're transported to hilar lymph nodes, which causes the blackening of the tissues. The inhaled carbon particles, they are engulfed by the macrophages. They are then transported to hilar lymph nodes, which causes the blackening of the tissues. The aggregates of carbon dust may induce fibroblastic reaction or emphysema, which may lead to conditions called coal workers pneumoconiosis. So the aggregates of carbon dust may induce fibroblastic reaction or emphysema that may cause the coal workers pneumoconiosis. Thus, you already know that coal workers, the carbon particles are inhaled and that goes into the lungs. The macrophages engulf that, and then they are transported to lymph nodes, hilar lymph nodes, and this causes the blackening of the lymph nodes. And in the microscopy here, you can see the black dark colored depositions. These are the carbon particles deposited. That is called the uh, anthracotic pigmentation. Okay, now let's talk about this. A 58-year-old man, he dies 24 hours after the onset of substernal chest pain radiating to the left arm. On autopsy, an atheromatous plaque was seen obstructing the left anterior descending artery. And which type of calcification is most likely to seen in this condition? Calcification, it is asking. So the options are dystrophic with increased serum calcium, and metastatic with increased serum calcium, dystrophic with normal serum calcium, or metastatic with normal serum calcium. So you have to remember, dystrophic is seen in dead cells. Okay, dead cells. Dystrophic is seen in dead cells. So with increase, which type of calcium is most likely to be seen in this condition? It is seen in, okay, it is seen, but in it is dystrophic with normal serum. So dystrophic is seen in dead cells, and this is due to normal calcium levels. In metastatic, serum calcium levels are increased, but here the cells are death because here the uh, autopsy was done. So the after death you can see the dystrophic calcification, death for dystrophic. Okay, so in dystrophic, you will see the normal serum calcium level. So when the deposition occurs in dead or dying tissue, it is called the dystrophic calcification. This occurs in absence of derangements in calcium metabolism. The calcium levels are normal. Dystrophic calcium is seen in areas of necrosis of any type. Some examples include atheromas of advanced atherosclerosis. It is common in areas of caseous necrosis and tuberculosis. So if you see, dystrophic calcification is seen in areas of necrosis of any type. Some examples include atheroma of advanced atherosclerosis. It is common in areas of caseous necrosis and tuberculosis also. Hypercalcemia can accentuate dystrophic calcification. Next question, let's go for next question. Metastatic calcification occurs in all except. So metastatic occurs in all except, not in atheroma. Okay, just now we started, because in atheroma what happens? In atheroma what happens? The after atheroma, the cell become death. Okay, so here that's why metastatic. So dystrophic is seen in atheromatous plaque. So automatically metastatic is seen in kidney, fundus of stomach, and pulmonary veins. So the major causes of hypercalcemia are increased secretion of parathyroid hormone due to malignant tumors. Metastatic calcium can occur in normal tissues whenever there is a hypercalcemia. So metastatic with hypercalcemia. Okay, the major causes of hypercalcemia, increased secretion of parathyroid hormone due to malignant tumors. What is the function of parathyroid? It will take out the calcium. It called desorption of bones and take out the calcium from the bones and so increase the serum blood calcium level. Okay, serum calcium level. Paget's disease also causes hypercalcemia, immobilization or tumors, increased bone catabolism associated with multiple myeloma, leukemia, skeletal metastasis, renal failure, vitamin D intoxication, and sarcoidosis. Metastatic calcification can occur throughout the body but mainly affects the interstitial tissues of vasculature, kidneys, lungs, and gastric mucosa. Okay, so metastasis can occur throughout the body, but mainly it affects the interstitial tissues of the vasculatures like kidneys, lungs, and gastric mucosa. Vasculatures. So, Which of the following stains is not used in detection of calcium in tissues? For calcium detection, what do you need? Okay. So for calcium detection, which stains you need? So for calcium detection, you need Congo reds. Okay. Congo red dye is used for staining amyloid, which are abnormal but extracellular deposits found in liver, kidney, and spleen. Red to apple green bifringence occur when viewed by polarized light due to the alignment of dye molecules on the linearly arranged amyloid fibrils. So what was the question? Which of the furniture is not used in the detection? So Congo red is not used because it is for amyloidosis, and Von Cosa stain you can use, Azan stain, alizarin red stain you can use, but Congo red is specific for amyloidosis. Remember this. Amyloidosis, yeah, it is used for amyloid bodies. Amyloid bodies are the abnormal, which are abnormal fibrous extracellular proteinaceous deposits that are found in liver, kidneys, and spleen. Red to apple green bifringence occur uh, when viewed by polarized light. When viewed by polarized light due to dye molecules on linearly arranged amyloid fibrils, you will get the apple green bifringence. Which of the following is used to stain calcium in tissue sections? Von Cosa, right? Just now we studied Von Cosa. So see here. Which of the following is used to stain calcium in tissue sections? Von Cosa. Von Cosa, okay. Von Cosa, Azansen, Alizarin cell, red dyes, these are used, okay. Special stain for calcium tissue is the Von Cosa or Alizarin red. Best method to demonstrate mineralization of bone is tetracycline labeling index. So here you can see the table of various stains. This will be very useful. H&E stain is the most common stain and it is used in routine histopathology. Papinicolis stain is a universal stain for cytological preparations. PAS is for demonstration of glycogen, mucin, fungi. Okay, mucin, fungi. For we use which stain? PAS stain. Okay, macrophages in Whipple's disease. Macrophages in Whipple's disease. So this stain is very important. PAS is for the glycogen, mucin, fungi, macrophages in Whipple's disease, adenocarcinomas, glycogen positive tumor, Ewing sarcoma, renal cell carcinoma. Alcine blue is for acid mucins, positive state for mucins of the intestinal mucosa and negative state for mucins of gastric mucosa and Brunner's gland. Pearl's Prussian blue is for hemosiderin and iron. For hemosiderin and iron, you have to use the Pearl's Prussian blue. Mason Fontana stain is for melanin in nevus and malignant melanoma. So malignant melanoma or it is melanin, you have to use Mason Fontana stain. Von Cosa method is for demonstrating the calcium. Van Giesen stain. Van Giesen stain demonstrates collagen, spindle cell neoplasm, and delineate extent of fibrosis, differentiated amyloid from collagen. Differentiated amyloid from collagen. Van Giesen stain. Mesenchymal stain is for collagen and muscle in connective tissue disorders, muscle and fibroblast tumors, liver cirrhosis, and neuromuscular disease. Reticulin stain and wire and oil red or Sudan black is for the fat or lipids. Okay, liposarcoma, all that. Van uh, Herf's method is to demonstrate fibers in elastin fibers. Okay, now let's talk about the which of the following stains is used for the detection of hemosiderin deposits. Hemosiderin deposits is used for the detection of hemosiderin deposits. Just now we studied for hemosiderin for iron. What we have to use? Pearl's Prussian blue. Pearl's Prussian blue for hemosiderin or iron related. Okay, hemoglobin derived stain is used to detect hemosiderin deposits. Is hemoglobin derived granular pigment that is golden yellow to brown and accumulates in the tissues where there is a local or systemic excess of iron. Iron is normally stored within cells in association. So here you can see like this hemosiderin deposition. So iron is normally stored within cells in association with protein apoferritin, forming ferritin micelles. Large aggregates of these micelles are hemosiderin deposits seen in both light and electron microscopy. Increased incidence of cancer in old age is due to, so in old age cancer it is because of the telomerase reactivation. Reactivation, here the telomerase is reactivated. Normally that every time when the division is taking place the telomerase will reduce. So for the the cell cycle to continue for the cell to divide again and again, the telomerase will regenerate. So if there is excessive regeneration of telomerase, then the cell will continue to divide. So increased incidence of cancer in old age is due to telomerase reactivation. With every cell division there is some shortening of telomerase at the ends of chromosome. Once the telomerase is shortened beyond a certain point, it may cause cell cycle arrest, apoptosis. This is called replicative senescence. But if the telomeres are regenerated again and again, then it will lead to the cancer. Every cell division, there is some shortening of telomeres at the ends of chromosome. Once the telomeres are shortened beyond a certain point, it may cause cell cycle to arrest or apoptosis. Replicative. Telomerase is the enzyme that prevents the shortening of telomeres. Telomerase is the enzyme that prevents the shortening of telomeres. So telomerase is the enzyme that prevents the shortening of telomeres. Telomeres. Okay, telomerase is the enzyme which prevents the shortening of telomeres. Telomerase is the enzyme. It prevents the shortening of the telomeres. Prevents the shortening of. So this enzyme is present in some cells like the germs and absent in most somatic cells. So reactivation of telomerase enzyme is a critical step in the development of 85% of human cancers, which enables the cells to divide for several times the normal of about 85% of human, that is reactivation of telomerase. Telomerase should be activated only in the germ cells because germ cells have to divide, but not in the somatic cells. If it is activated in somatic cells, then the person will end up having cancer. All are true regarding sirtuins except reduce apoptosis, stimulate protein foldings, and reduce insulin sensitivity increased by caloric restriction. So all are true regarding certains except, so they reduce insulin sensitivity. See sir, this is wrong statement. Okay, they reduce apoptosis, correct. They stimulate protein folding, they increase caloric restriction, yes. They are increased by calorie restriction. Certains can cause increase insulin sensitivity. Increase. So it has potential in the treatment of diabetes. You can use them. Certains are a class of proteins that regulate the cellular response to stress, ensure the damaged DNA is not propagated, thereby countering the accumulation of mutations. Most effective way to prolong lifespan is caloric restriction, and red wine induced certain are present. Red wine certains are there. So best to prolong your life is calorie restriction. If you eat less, you are healthy. Calories restriction is important. Werner syndrome. What is Werner syndrome? What is Werner syndrome? Men 1, men 2, premature aging or defective circuits. So premature aging is Werner syndrome. Premature aging. Patients with Werner syndrome show premature aging. The defective gene product is DNA helicase, a protein involved in DNA replication and repair. The defect causes the rapid accumulation of chromosomal damage. Honesty should not be confused with Werner syndrome, that is multiple endocrine neoplasia, type 1, a heritable disorder characterized by abnormalities involving parathyroid pancreas, and pituitary gland. Premature aging in Werner syndrome is due to premature aging in Werner syndrome is due So, Werner syndrome is due to the defect in the DNA helicase enzyme, due to which all the damaged chromosomal DNAs are accumulated, which mimic the injury that normally accumulates and causes cellular injury. So, which of the following stains is used for staining melanin? We have discussed anything for melanin will be Masson Fontana stain, melanin or melanomas. Which of the following Masson stain is used to stain melanin? Melanin is a brown black endogenous pigment. It is used to stain argentaphane granules, which are normally present in endocrine cells in duodenal mucosa and pathologically seen in carcinoid syndrome. It is also used to stain the argentaphane granules, which are normally found in the endocrine cells in duodenal mucosa, and pathologically it is in carcinoid syndromes. Now let's start with our next chapter, that is inflammation. A 60-year-old woman, she presented with progressive dyspnea at rest. Okay, chest X-ray showed significant right-sided pleural effusion. She is having the pleural fluid analysis reveal a transudative pleural effusion. All the following statements are true about transudate except. So, 60-year-old woman is there. She is presenting with progressive dyspnea at rest. Her chest X-ray is showing that she has a pleural effusion. The pleural fluid analysis revealed a transudative pleural effusion. All the following statements are true about transudate except it is high protein content, low specific gravity, little or no cellular material, ultrafiltrate of blood plasma. So all are correct except it is not in high protein. Transudate is a fluid with low protein. So, what is the difference between transudate and exudate? See, transudate is a passively the thing is collected, okay, fluid is collected, and exudate actively collected. Here, vascular permeability is normal. Here, it is increased. Plasma protein leak is absent, here present. So, exudate is rich in protein, not transudate. So, transudate is low in protein, little or no cellular material, and low specific gravity is there. It is essentially an ultrafiltrate of blood plasma that is produced as a result of osmotic hydrostatic imbalance across the vessel wall without an increase in vascular permeability. So it's an ultrafiltrate which is produced due to osmotic and hydrostatic imbalance, not due to increased vascular permeability. Increased vascular permeability is exudate. So here you can see the difference. This difference is very much important. So remember this. Transudate is a passive process. Here because of the increased pressure. Exudate is active because of inflammation. Here the vascular permeability is normal. Here the vascular permeability is increasing. Here the plasma protein is absent. Here the plasma protein leak will be there. That's why here protein content will be more in the exudate, not in transudate. Okay. Protein content of fluid here low specific gravity. Here high specific gravity because protein is there. Here protein is less than 1.5 gram per dl. Here proteins are more because here the vascular permeability is increasing. Here fibrins are absent, here fibrins are present. If it is an exudate, fibrins are present. Inflammatory cells are absent, here the inflammatory cells are present. Understood? All the following vascular changes are observed in acute inflammation except. All vascular changes are seen in acute inflammation except. So in acute inflammation, vasodilation. Stasis of blood, yes, for some time. Vascular permeability, decrease hydrostatic pressure. So see here, what's the answer? Decrease hydrostatic pressure. So here vasodilation will be there, stasis of blood is there, increased vascular permeability is there, decrease hydrostatic pressure is not there. The hydrostatic pressure is increased. Vascular events and acute inflammation, if you see, first vasodilation, it causes of erythema and stasis of blood flow. The blood flow is reduced in the sense slow down, sluggish, it will slow down and causes erythema, redness. So dollar, rubor, calor, all these will occur because of vasodilation. The erythema, redness will occur because the sashes of blood flow is there. Increased vascular permeability induced by histamine, kinins, etc. Increased vascular permeability. Increased vascular permeability allows plasma protein leukocytes, the mediators of host defense, to enter sites of infection or tissue damage. So where the site of infection, tissue damage is there the proteins, leukocytes, they will go and migrate. Fluid leak from blood vessels resulting in edema, swelling. Okay. All the following are integrin molecules except. Talking about integrin molecules, so all are integrin molecules except. So all are integrin molecules except the CD31. CD31 is the not an integrin molecule. It is a platelet endothelial cell adhesion molecule. Platelet endothelial cell adhesion molecule, that is platelet endothelial cell adhesion molecule 1, PCAM1, is a member of immunoglobulin superfamily. It is a immunoglobulin superfamily member expressed on endothelial cells. It is a member of immunoglobulins. It is expressed on endothelial cells, blood vessels, endothelial cells. Okay, and the platelets and subleukocytes are involved in migration of leukocytes. The others are LFA1, MAC1, VLF4. Okay, are integrins. So addition molecules. What are selectins? Addition molecules. Addition molecules are the selectins. What are the integrins? LFA1, MAC1, VLA4. But what are addition molecules? Addition molecules are selectins. Selectins, addition molecules, initial rolling interaction between leukocyte and endothelium. So here the blood vessel is there, the endothelium is there, endothelium is there. Initial rolling interactions between leukocytes. Here the leukocyte is there, endothelium. So the rolling interaction, the leukocyte will roll on the endothelium. So that is by selectins. Integrins, firm addition of leukocytes to endothelium. Firm addition it will give of leukocyte to endothelium. Selectins, initial rolling interactions. So here it will connect, then detach like that. So immunoglobulin family, PCAM, most important addition molecule, diapedesis. Diapedesis means the leukocyte will cross and go. ICAM1 binds to beta 2 integrins on leukocytes. ICAM it binds to beta 2 integrins or on leukocytes. So if you see PCAM is most common, most important addition molecule for diapedesis, and ICAM1 it binds to beta 2 integrins on leukocytes. A 42-year-old male patient is admitted to the ICU with acute respiratory distress syndrome. Which of the following cells play a significant role in tissue injury caused by inflammatory response? So there's a 42-year-old male patient and he is admitted to the ICU and he's having acute respiratory distress syndrome. Which of the following cells play a significant role in tissue injury caused by inflammatory response? So there's a 42-year-old male. So there is a 42-year-old male and he is admitted to the ICU with acute respiratory distress. Which of the following cells play a? But before this, did you? It is important to remember this addition molecules. So let's selectins, integrins, and immunoglobulin family like PCAM and ICAM. PCAM is platelet endothelial cell adhesion molecule 1, and ICAM it binds to beta 2 integrins on leukocytes. Beta 2 integrins on leukocytes. So ICAM binds to the beta 2 integrins on leukocytes. So ICAM it binds to leukocytes. Okay, on leukocytes beta 2 integrins are there. It will bind to that. So addition molecules are selectin, integrins. Integrins are what? Integrins are LFA1, MAC1, MAC1, and VLA4. Okay. Selectin, it causes the rolling. Selectin causes the rolling. Selectin causes the rolling. Okay. Selectin causes the rolling. Just the charging. 55. So PCAM. It's not working. Okay. So selectins, integrins, and immunoglobulin families like PCAM 1 and the ICAM 1. ICAM will bind to the integrins on the leukocytes, beta 2 integrins on the leukocyte. Selectins, they cause rolling. It's not working. Integrins, they cause the leukocyte adhesion, foam adhesion of leukocytes with the endothelium. So, what is the work of the integrins? Integrins will cause the addition of leukocytes to endothelium. Next, what is next? A 42-year-old male patient, he's having acute respiratory distress. He's in ICU, and which of the following cells play a significant role in tissue injury caused by inflammatory response? So acute is then, for acute you have neutrophils. For acute you have the neutrophils. For acute you have the neutrophils. So acute respiratory distress and induced tissue injury is caused by neutrophils. ARDS is a clinical syndrome manifested as a result of severe lung injury characterized by inflammation. It causes increased pulmonary vascular permeability, edema, damage to endothelial and alveolar cells with inflammation, key initiating event. ARDS neutrophils adhere to activated endothelium and migrate into the interstitium and alveoli. They degranulate and release inflammatory mediators. So see here. ARDS, acute respiratory distress neutrophils adhere to the activated endothelium and migrate into interstitium of the alveoli, where they degranulate and release inflammatory mediators, including proteases, reactive oxygen species, ROS, and cytokines. Okay, so these all causing inflammation. If an inflammatory response to infection is found and the inflammatory infiltrate is predominated by neutrophils for several days beyond usual 24 to 48 hours, which of the following is made likely? So it is directly asking the exception. So whether it is Pseudomonas or fungi or Staphylococcus or virus, so it might be Pseudomonas, because Pseudomonas is a bacteria. Okay, and it should be acute infection. And for acute infection, neutrophils are there. But here in this case, it is a chronic infection, but neutrophils are there. So it's an exception. Certain infections, for example, are produced by Pseudomonas bacteria. The cellular infiltrates is dominated by neutrophils for several days. Nature of leukocyte infiltrate in inflammatory response. In acute inflammatory response, neutrophils predominate for the first 6 to 24 hours and are replaced by the monocytes in 24 to 48 hours. In 24 to 48 hours, they have to be replaced by the monocytes. This is because neutrophils are short-lived, they undergo apoptosis and disappear within 24 to 48 hours. Monocytes become the dominant population, prolong inflammatory reactions. Exceptions of the stereotypic pattern, like the pseudomonas, viral infections, and hypersensitivity. Cell line is dominated by continuously recruited neutrophils. So pseudomonas is the exception. What are the exceptions? Pseudomonas, viral infections, and hypersensitivity reactions. Which of the following component of the complement system is an endogenous chemoattractant? Endogenous chemoattractant, okay? It is C5A. C5A is the endogenous chemoattractant. C5A, endogenous chemoattractant, attracting uh, the immune cells towards the pathogen. So, the most common exogenous are the bacterial products. Most common exogenous agents are the bacterial products, exogenous agents. But endogenous substances, both exogenous and endogenous substances, can act as chemoattractants. So, chemotaxis is locomotion along a chemical gradient. Leukocyte move towards the site of injury. Endogenous chemoattractants in several chemical mediators, cytokines, particularly those of the chemokine family, interleukin 8. Okay, components of complement system, particularly C5A and arachidonic acid metabolites, meaning leukotriene B4, LTB4. So learn these, note down somewhere in your book. This is really important. What are the endogenous chemoattractants? Endogenous chemoattractants are of different types. One is cytokines, the most involved in chemotaxis, interleukin 8. In complement system, it is C5a. In arachidonic acid metabolites, leukotriene B4. Okay, learn this. Next, which of the following is an opsonin? Which of the opsonin means what it will do? What is the function of opsonin? Opsonization is the coating of the foreign particle and preparing it for phagocytosis. Substances involved, they are called the opsonins. So opsonins, they coat the foreign particle and make it takes the for the macrophages to engulf. Okay. So what is the opsonin? So here the opsonin is C3b. C3b is the opsonin. What is C5a? C5a is the C5a is the what is C5a? C5a is the, just now we studied, it is the chemo attractant. Okay, which interleukin is chemo attractant? Interleukin 8. Arachidonic acid is 8 one, right? Arachidonic acid LB in, that is leukotriene B4. B4, leukotriene B4, not 8, B4. Okay, interleukin 8, leukotriene B4, and C5a. So opsonins, what are the opsonins? They coat the foreign particle and make it tasty. Okay, so this is called opsonization. C3b is the opsonin. Example C3b, C4b, C5b, IgM, Fc receptor of IgG, fibrinogen. So here if you see, so these are the opsonins. C5a is the chemokine. So they are chemokines are the substances that influence the migration of leukocytes to the site of inflammatory loci. Examples is C5a, LBT4, LTB4, IL8, and bacterial products. Talking about all our antioxidant mechanisms that protect against oxygen-derived free radicals, except which one? Ceruloplasmin or the catalase or glutathione? Which one? Except, it is saying except the myeloperoxidase. See, all are antioxidant mechanisms to protect against oxygen-derived radicals except myeloperoxidase. Myeloperoxidase is an oxidative enzyme. It is an oxidative enzyme that has antimicrobial activity, which uses H2O2 to produce hypochloric acid and other toxic substances. So myeloperoxidase is an oxidative enzyme with antimicrobial activity, which uses H2O2 to produce hypochloric acid and other toxic substances in neutrophil phagolysosome. It is used in azerophil or primary granules for neutrophils. It destroyed microbes. So actually myeloperoxidase, it breaks down the H2O2 and after it produces hypochloric acid. This hypochloric acid and with some nascent oxygen like free radicals are there, they will cause the phagolysosome of the neutrophil phagolysosome. So it is seen in azerophil or primary granules of neutrophils. Neutrophil phagolysosome, this process of breakdown of H2 hypochloric acid will produce the radicals that will destroy the microbe. Okay, so it is seen as acidophil for granules. So the H2O2 MPO, the H2O2 MPO, the H2O2 MPO halide system is the most effective bactericidal system of neutrophils. That is MPO myeloperoxidase. So it kills the bacteria by myeloperoxidase. The antioxidants include superoxide dismutase (SOD), superoxide dismutase, enzyme catalase, glutathione peroxidase. Another powerful H2O2 detoxifier is glutathione peroxidase. The copper containing serum containing ceruloplasmin, the copper containing serum protein ceruloplasmin, and the transferrin, the iron free fraction of serum transferrin. So these are the important thing, you can learn this. Okay. A 7-month-old boy, he presented with a 2 days history of fever, and he's having abscess over the neck. The mother reveals that the child has similar recurrent infection in the past. The result of nitroglycerin dye reduction test was found to be abnormal, which is the most likely diagnosis. So it is chronic granulomatous disease because he's having recurrent abscesses. This chronic granulomatous disease. Okay, so recurrent abscesses are seen in the chronic granulomatous disease. So the given clinical condition, history of abnormal nitro reduction blue test, nitrotetrazolium dye reduction test, uh, suggests a chronic granulomatous disease. The CGD is an X-linked recessive disorder. It is due to deficiency of NADPH oxidase enzyme. This NADPH oxidase enzyme is important in respiratory or oxidative burst. In CGD, there is an increased risk of catalase positive species like Staph aureus, E. coli, Aspergillus species linked to granulomas. The condition usually manifests in the first year of life with recurrent pyogenic infections with catalase positive organisms. Catalase positive organisms. So if you see here, it is an CGD, chronic granulomatous disease, is an X-linked recessive disorder due to deficiency of NADPH peroxidase. So in CGD, NADPH oxidase deficiency is there. This question is also USMLE or MRCB potential question, so must remember this. CGD is NADPH oxidase, which is important respiratory oxidative burst, and CGD there is an increased risk of catalase positive species like Staph aureus, E. coli, Aspergillus species leading to granulomas. The condition usually manifests in first few years of life. Now let's talk about chronic granulomatous disease is a defect due to NADPH oxidase. So NADPH oxidase is absent in the patient. But this NADPH oxidase is absent in the patient. But these Staph aureus, these species, Staph aureus, it has the catalase. So this interferes with the killing of bacteria by oxidative burst. But NADPH, it interferes the bacteria by oxidative burst. But here NADPH is absent. So the patient has high risk of infection from catalase positive bacteria. These catalase positive bacteria like staph species, E. coli, Aspergillus species. Primary granules in neutrophils contain all except. Primary granules in neutrophils contains all except. So it contains myeloperoxidase, just now we studied, yes. Acid hydrolases, yes. Difference in lactoferrin. Lactoferrin is not there, okay. So if you see this table is, we reduce size. Okay, it has been how much time? 1 hour approx. So let's conclude here. Then we'll discuss after break. Okay, lunch break. Let's talk about this. Primary granules of neutrophils contains all except lactoferrin. Okay, myeloperoxidase is present, which is a very strong bactericidal difference in acid hydrolysis. Lactoferrin is present in secondary granules of neutrophils, not in the primary granules. There are two main types of granules. The two means primary is called azidophilic, secondary is called specific. Secondary specific, primary is azidophilic. Azidophilic myeloperoxidase, bacterial factors like lysozyme defense in acid hydrolases, and neutral proteases, elastase, cathepsin, G, non-specific collagenase proteinase 3. Specific one contains the lysozyme, collagenase, gelatinase, lactoferrin, plasminogen activator, histamine, alkaline phosphatase. Granules can fuse with phagocytic vacuoles containing engulfed material, or the granules contents can be released into extracellular space. Alpha 1 antitrypsin is the major inhibitor of the enzyme. It's very important in the smokers. Uh, okay, this enzyme is uh, less, or I can say it's reduced in smokers, chronic smokers, causing emphysema. So these are important for elastase. Okay, so elastase. So these alpha 1 antitrypsin is the major inhibitor of the enzyme neutrophil elastase. Alpha 1 antitrypsin deficiency is caused by the mutations in SERPINA1 gene located on chromosome 14. As a result, serum levels of alpha 1 antitrypsin are decreased, leading to low alveolar concentrations, where the alpha 1 antitrypsin molecule normally would provide protection against proteases such as neutrophil elastase. The resulting protease excess in alveoli destroys alveolar walls and causes emphysema. This is a neat pattern type of MCQ. So this is present. This alpha 1 antitrypsin deficiency is caused by mutation in SERPINA1 located on chromosome 14. 14 emphysema, alpha 1 antitrypsin decreased, and because of the elastase such as neutrophil elastase, these nothing but protease. Such proteases causes the destruction, right, damaging the alveolar walls. The major basic protein is seen in eosinophils. The major basic protein, basic means eosinophil, also called proteoglycan 2, encoded by PRG2, is the predominant constituent of the crystalline core of the eosinophil granule. This protein is known to be involved in anti-parasitic defense mechanism as a cytotoxin and helminthotoxin. In it also causes lysis of mammalian epithelial cells and thus plays a role in immune hypersensitivity reactions. So this question has been taken from Robbins. So the major basic protein. So the major basic protein. Okay, the major basic protein is called proteoglycan. The major basic protein is called the proteoglycan. The major protein is called the major basic protein is called the proteoglycan PRG2, encoded by PRG2 gene, predominant constituent of the crystalline core of the eosinophil granule. The protein is known to be involved in antiparasitic defense mechanisms such as cytotoxin, helminthotoxin, caused by lysis of mammalian epithelial cells and thus present immune hypersensitivity reactions. So the following statement is not about neutrophil extracellular traps. How much is there still? My God. Okay. And information part 2, the TMCQs mode. So we are about to end. Okay, so here if you see, Which of the following is not true about neutrophil extracellular traps? They prevent the spread of microbes by trapping them in the fibrils. This is true. Nuclear chromatography in the nets may act as a source of nuclear antigen sacily. Substitute neutrophil activation. Okay. Pathogenic substances undergo phagocytosis by active nucleated neutrophils. In the process of neutrophil extracellular trap net, the nuclei of neutrophils are lost. Death of neutrophils. Hence, option D is false statement. The process of neutrophil extracellular trap net formation. Nuclei of the neutrophil are lost. So, in the process of neutrophil extracellular trap formation, the nuclei of neutrophils are lost, leading to death of neutrophils. Hence, option D is a false statement. See, the pathogens undergo fight caused by activated nucleated neutrophils. No, neutrophils are died. Nucleated, not. See, in the process of neutrophil extracellular terminate formation, nuclei of the neutrophils are lost, leading to death of the neutrophils. Hence, option D is not correct. See, neutrophils extracellular traps prevent the spread of microbes by trapping them in their fibrils. So these they are produced by neutrophils in response to the following: infectious pathogens if bacteria and fungi are there, inflammatory mediators, chemokines, cytokines, and interferons, complement proteins, and reactive oxygen species. So see this figure shows what? Incomplete questions. So this is what autophagy, emperipolysis, or phagocytosis, amoebic autophagy. So it is emperipolysis. The image shows emperipolysis. It is a phenomenon where hematopoietic cells in the living and intact state are seen in cytoplasm of the host cells without any damage. The cells frequently involve neutrophils, lymphocytes, plasma cells. Since both are cells viable, there are no physiological morphology considering neither of them. So we'll start these after the break. So next part 2 will come. So these are the questions which will be there in the part 2. So the first mediator to be released during inflammation, which are the findings of a source of histamine production. Anti-inflammatory cytokine is anti-inflammatory. Example of CXC chemokine. To which chemokine family does fractalkine belongs to? Are positive acute phase reactants. So meet you.